Hello, thank you for joining me today. I'm Dr. Diane Tracy Marandola. I'm a pediatric nurse practitioner and public health nurse from the U.S. I'd like to tell you about a journey that I took. In 2018, I traveled over mountains upon mountains from Bukidnon, Mindanao with STTI Psi Beta leadership. I had been with STTI and Mountain View College as a guest speaker. I addressed the needs of patients post-hospitalization. I spent a day speaking about the need for care coordination during transitions of care from hospital to home to over 150 nurses that were attending this continuing ed program. During this 3-hour trek, I learned that patients with complex illness who live at home in Negros Oriental do not benefit from the organized support of expert clinicians. As an advanced public health nurse, the thought that patients and their family members are going it alone after major hospitalizations for stroke, cancer, kidney failure, sepsis, heart disease, or major trauma was mind-boggling to me. And the thought that patients and caregivers are on their own for managing end-of-life needs was truly too much to bear. Fueled by this journey, I started thinking about my perspective for about 6 months. I decided to approach the problem as an opportunity to have a scholarly endeavor, very STTI-esque, I might add, and I created a research proposal. STTI Psi Beta accepted my proposal, and a member of the STTI leadership team came on as my partner. That's Maria Teresa Concepcion Belcina. We started by researching this problem and finding solutions. We got started using the public health W's. They are answering the questions who, what, where, when, and why. For example, who needs assistance? Who are our stakeholders to help us solve this problem? What are the needs? What are the strengths in the community that can be maximized? Are there tools in place already that we can use to create our model of complex care management? What framework should we use to guide our strategy? Where are the patients who need us? Where do they live? When do patients need support the most? And why hasn't this been done before? We took some building blocks as we got going. Alma Ata Declaration of 1978 put a spotlight on primary health care as its central means toward good and fair global health. There are 8 essential elements which promote practical, scientifically sound, and socially acceptable methods and technology, which make universally accessible health care to individuals and families that a community may afford. For our STTI Complex Care Project, we'll focus on element number 7, the treatment of non-communicable disease, and element 5, the provision of essential drugs. The next building block was a favorite of Silliman's School of Nursing, Dean Saicinda. She was a champion of revitalization of primary health care, and she invited me to assist her in promoting RPC across Dumaguete. And during this process, she showed me the pride the community takes in its members and also how to mobilize for a cause. She taught me how to move within her community. And while revitalization of primary health care includes primary care. Primary health care is about a community coming together to solve its health problems with all the resources it may muster. Another building block is the service delivery network. In 2008, the Philippine Department of Health Administrative Order 0029 created the service delivery network. Its intention was to integrate private and public sectors into a holistic system, to create a referral system that makes health service delivery effective and efficient and operational. Its goal was to deliver integrated care across a continuum of needs, as no single facility or unit can provide all services. Mindanao brings an awesome example with its maternal child service delivery network model, which they achieved in collaboration with USAID and Johns Hopkins University. Another very current, exciting building block is the Universal Healthcare Law passed in the Philippines in 2019. It shouts that it is time to advocate for access to care for patients who have complex care needs. Our project's focus will be on patients with complex care needs across the continuum of illness who are in need of services at home in their own barangay. So, AMA-ATA, revitalization of primary health care, the service delivery network model, and universal health care all come together as communities solve their own problems. From a project management structure perspective, we've got quite a few things to do that will give order to the scope of the project that we're involved with. We're going to be real clear on defining the problem, and that definition is going to be clearer and more focused as the project moves along. We'll complete a community needs assessment. We'll use data from surveys of our stakeholders, including patients, to help customize any activities that we might be inspired to use from the literature. We'll do a complete review of the literature that looks at Dumaguete, Philippine, global health perspectives on complex care initiatives. We'll identify data at the front end that we can track over time so that we can see the improvements that we make in any of the key data pieces that we identify. This will help us to support achievement of outcomes and help us to manage the outcomes that are the driving forces of goal setting and objectives that we hope to accomplish. We'll have a timeline. We'll have project management strategies. We'll write it up and we'll disseminate it to the clinical and non-clinical people that help us to achieve our objectives. The principles of health system design that we'll be using go back to the structure pieces of AMA-ATA, revitalization of primary health care, service delivery network, universal health care, project management. Those will give us our structure so that we have a cohesive piece by the time we're finished. We'll identify some key policy frameworks that we'll advocate for as a result of the direction that we obtain in our structure. We'll set up processes, workflows, policies, procedures, all activities that are not new to nursing services, but we'll apply them in a new way And we'll use outcomes. We'll manage our outcomes for goal setting, for adjusting during various check-in points during our project to make sure that we are on track. Our goal? Improved outcomes in transitioning patients from hospital to home to barangay. So far, we've validated that indeed there is a gap occurring when patients with complex illness transition from hospital to home in their barangay. We will be highlighting the role of an interdisciplinary team to plan for care of patients in their home. We will tie our planning to primary care, the hub of patient care access across the continuum. We will seek to maximize PhilHealth coverage of care, and we will seek to maximize access to medication. We will determine patient and caregiver needs, and that will include patient assessment, disease management, medication education and management, care coordination with local physician, family education and support through the help and guidance of an interdisciplinary care team. The problem is such a big deal, and it's at the top of our project management structure. Right now, we're identifying the problem that there is a gap in health service delivery as patients with complex care needs transition from acute care hospitals to post-acute care as they rehabilitate at home. Our patient population is the population of people with multiple chronic illnesses and patients who can benefit from end-of-life care from our expert clinical team that we seek to put in place. Our rationale is that patients and families need support from clinical experts for education around illness care and medication management. There will be many times over the next years to highlight the essential role that the Philippine patients, family, and caregivers play in helping their loved one to be secure at home. We value that and want to support the success and management by those individuals. We anticipate referrals to clinical experts that will be processed and evaluated with a quality and patient satisfaction lens. Our solution. The goal of our project is to work with stakeholders to define a complex care coordination model in order for patients to benefit from consistent transitioning from hospital to home. We will identify community partners. We'll create an administrative team. We'll create a clinical team. Our model will support self-resilience of patients and caregivers. Our model will coordinate care with the patient's physician, hospital, and community resources. And our model will have medication reconciliation as a key principle of outcome objective. Again, our timeline, phase 1 is to create the model in 2 years and test the model in 2 to 5 years. Our project administrative team is the group that's going to make this project happen from an administrative perspective. STTI will be a convener of stakeholders and grassroots supporters. We need to cultivate relationships and identify community leaders, such as attorneys, PhilHealth representatives, faith-based representatives, nurses, physicians, rehab specialists, to come together to support the operations of a clinical program, to include marketing, fundraising, advocacy, and policy setting at the government level. We will seek every opportunity for collaboration to advance our work, for bringing clinical support to patients with complex care needs who need help at home. Our clinical team will run against a continuum of needs from supportive to palliative to hospice care. Supportive care is that care for patients with multiple complex illness who need help to stabilize their disease, combat the depression that often accompanies complex illness, and to achieve a higher level of wellness. Palliative care is for patients with unstable disease, such as progressive congestive heart failure or end-stage renal disease, who need specialists advising them, their primary physician, or mobilizing the community to support their needs at home. Hospice will be for support of end-of-life care. Hospice philosophy's focus is on care, not on cure. It recognizes death as a natural part of life. It is care for the whole person and their family. And it addresses everyone's pain and the patient's physical, psychological, spiritual, social, and emotional pain. Having run a hospice program, what I learned is that when you stabilize physical pain and emotional pain and spiritual pain, patients live longer because their load is lightened. So, such a great opportunity to bring comfort and the process of pain management to the patient experiencing end-of-life care. One of the things that we've identified in doing our stakeholder surveys is that there was a referral system of patients from hospital to home that was already in place, but really could benefit by an enhanced assessment and actualizing the referral system. So we see an opportunity to boost information on the referral setup, on patient status, family support, medications, and the resources patients may need when they get home. We want to track referrals and see where we may improve them. We want to study communication between referrer and referee. We anticipate rigorous quality reviews to be done on each referral as we fine-tune processes and optimize outcomes. Dumaguete has identified a barangay nurse who will pilot receiving referrals, and Dipolog has traced its referral process and does action planning with referrers to improve their process. Down the road, we anticipate 5 areas of opportunity for taking action: to support patients and caregivers, to provide training and professional development in supportive, palliative, and hospice care, in promoting community awareness of our Center for Complex Care Management. We want to advance clinical, administrative, and financial policies and practices that patients with complex care needs need to thrive. And we seek to collect, analyze, and share data and findings from research to practice. The complex care team has been asked to work with the City Health Officer, Dr. Sarah Tala, a physician, to help her with her 2019 public health priority of providing enhanced care to patients with mental health needs and mental illness. We anticipate that we will adapt our supportive, palliative, and hospice program strategies to meet the needs of those with mental illness. As we come to the end of this presentation, I'm sure that there are many questions that you're asking yourself and would like to ask me. Please email me or connect with me on Facebook or LinkedIn. If you connect with me on LinkedIn, I always enjoy forwarding different articles and programs to the people that do follow me on LinkedIn. Do you know of resources that the project team should be tapping into? Please let me know. Are you a resource that can help us move this project along? Please let me know. And do you want to start such a program in your community? I am here to help you. Thank you all for your time and consideration. Mabuhay.